That was a great lecture by Dr. Miralles. And now it's an honor to introduce the next speaker. Dr. Stoller is the assistant professor of medicine at Harvard Medical School. He's also the director of GI Motility Laboratory at Massachusetts General Hospital in the Division of Gastroenterology. And he's going to talk about pneumatic dilations. So over to Dr. Stoller.
Well, thank you for the introduction, and really it's a pleasure to be here. Of course, it would be more of a pleasure if we saw you in person, but we have a lot more opportunities with virtual conferences now and a wider audience. And I'm going to talk to you about the current management of achalasia, and specifically pneumatic dilation. And I want to present to you a somewhat biased view toward pneumatic dilation because there's so much enthusiasm for some of the other things that are out there in terms of treatment of achalasia. These are my disclosures. None of them are relevant to the talk that we're going to be talking about today. So first, a review. You know, there's probably a mixed audience here in terms of what they've done, if they've done these procedures before, if they've seen these procedures before, or they're thinking about getting involved with these procedures. Unlike the poem, of course, which you just heard about very eloquently from Dr. Miralles, this is a technique that's been around for a long time. And of course, the idea here is to disrupt the lower esophageal sphincter muscle fibers with radial force using a balloon. And this technique dates back, as I said, many years, but it really grew into its own in the 1960s. And of course, the technology that we use has evolved, and so we have better equipment. And this is the very typical equipment that you will see when you do a pneumatic dilation. This is a squeeze bulb with a pressure meter here, and this is connected to a rigid catheter that is a non-compliant balloon. And then you can see these radio-opaque markers that help you define the balloon location. And it's important to note that this is a non-compliant balloon. So this is different than the CRE or the through-the-scope balloons that many of you may be used to using, that often still, despite being fully inflated, will still have a little bit of a waste. When this bad boy is inflated, it's inflated all the way, just as you see there on the table. And so it is very non-compliant, okay? And of course, just for reference, the baseline balloon diameter here is 30 millimeters, and that compares to 20 millimeters, which is the maximum size of the through-the-scope balloons that you may be used to using. The catheter diameters, as I mentioned, start at 30 millimeters, and that's generally where we start most of our dilations. But then they go up to 35 millimeters, and we use these frequently. 40 millimeters, these are relatively infrequently used. This is a big balloon, as you can imagine. So technique-wise, what happens here? So endoscopy is used to pass the guide wire into the stomach, and then that catheter, which you saw on the previous slide, is advanced over the guide wire. One of the key, most difficult parts of doing this procedure, in my opinion, is finding the lower esophageal sphincter on fluoroscopy. Of course, you can find the GE junction on endoscopy, but you are not usually doing this under endoscopic guidance when you're doing the procedure itself. And so you're trying to find these radio-opaque markers. You're trying to get them to a point where you think the lower esophageal sphincter is. And I do this kind of in multiple different ways. One of the ways is that with the endoscopy or with the endoscope in place, I mark the location with a Kelly clamp that's clipped onto the patient's gown, and you can see it coming in here. This is one of our images. Also, I'm marking on the length of the catheter where the lower esophageal sphincter is, or I should say the GE junction is, with a little piece of tape. And so it's sort of a belt and suspenders because I know the biggest struggle that I have is not inflating the balloon, it's finding the balloon to the right place. And so then once the balloon is finally what I think in the right place, I'm going to start to slowly inflate it. As I slowly inflate it, if I'm lucky, I'm going to start to see this nice waist here that's really hopefully centered over the middle marker of the catheter. And that tells me that I'm perfectly located. Now, truthfully, in reality, I'm going to, in real practice, I'm going to inflate this and I'm going to see the waist above or below where I want to be. And then I'll have to deflate again, reposition the balloon because we know the esophageal length is dynamic, and then go ahead and inflate again. Now, once I have this ideal picture, then I'm going to inflate all the way up. And you can see now, you can see that again, that balloon is not compliant. And now the balloon is a fat sausage here, and you are stretching the lower esophageal sphincter. You've made that waist disappear. Now, inflation can be held for a variable amount of time, and it's not very consistent in terms of what the best time is. The literature, you'll see anywhere from 15 seconds to 2 minutes. We do a minute. Other people that I know do 30 seconds. Again, a little bit of controversy, or at least not a consensus as to what's the best. What about the efficacy of pneumatic dilation overall? So initially, the reports were 61 to 76%, which were a good or excellent response. In a graded type of phenomenon, which is really what we do in real time, you start with a 30 millimeter balloon, and then depending on the efficacy, you may shortly thereafter follow with a 35 millimeter balloon. Now, this is not happening at the same endoscopy, right? This is happening several weeks later, and the efficacy in some series has increased to more than 90%. Now, this is important. A third of people may have relapse after 4 to 6 years. And so here's really where you may be doing multiple dilations over time. And that's the difference between pneumatic dilation, which we sort of say there is a built-in relapse rate that we expect and we prepare patients for, and the other types of procedures, both POEM and myotomy, where it's for the most part a one and done. And when it's not, it's more of a rarity. Now, what are the predictors of some of the failure of pneumatic dilation? Well, these are patients who are male, generally those who are younger, those who undergo only a single dilation, and then of course, type 3 achalasia, right? Type 3 achalasia is a straight to POEM in my book. I think the data is there and to do sort of this directed myotomy rather than going through pneumatic dilation. But sort of younger male patients, we're going to try and push them away from pneumatic dilation. Older female patients, they may be someone who may benefit from considering pneumatic dilation in your arsenal. Complications are a big issue here. And the biggest concern, of course, is an esophageal perforation. And, I always tell patients when I'm consenting them for this procedure that, a perforation in the mediastinum is very different than a perforation in the peritoneum. And so the complication could be very severe if this happens, as opposed to a perforation that you might have during a colonoscopy. So the European achalasia trial, which is really the landmark trial in terms of pneumatic dilation, which we'll talk about in more detail subsequently, they had a relatively high perforation rate. So it was 4%. But a lot of that was driven by using that middle-sized balloon up front. So these were patients where they sort of figured, okay, these are people who probably are going to need a 35 millimeter balloon. That's where they saw the majority of their perforations rather than starting more conservatively. Now, a large US center, which is very experienced in pneumatic dilation, reported a rate of 0.37% over 12 years. I think on average, the rate's probably more in the 1% to 2% if we're going to say a realistic perforation rate. Our practice in terms of what do we think about for perforation? Well, if we see a perforation, we're going to try and treat it right then. And that's the case in terms of doing stenting or clipping. But in terms of helping us sleep at night, we do a contrast esophagram prior to discharge. Others may just monitor the patient for 30 to 60 minutes after recovery. Recent guidelines, which again, I'll review later in this talk, have suggested that no imaging is really needed. But for patients who are potentially coming to Boston from further afield, I sleep better at night knowing that they've had a contrast esophagram before they go home and that there's not a perforation. Again, with a belt and suspenders approach, I also will inject contrast while under fluoro during the procedure to see if there are any obvious leaks outside of the esophagus that may be amenable to endoscopic repair. And perforation, we talked about this. Previously this was a straight to surgery, but now often with clipping or stenting alone, we can avoid surgery. Patient still needs antibiotics and hospitalization, still something that we want to avoid, but the person is not necessarily going straight to the OR. What about people who are older, right? And so the old maxim that is still held by many people is to never perform a pneumatic dilation in a patient that you wouldn't refer for surgery in the first place. I would argue that maybe a new maxim could be that you could consider pneumatic dilation in patients that others won't touch. And this is some data that we recently presented. One of our fellows, our motility fellow from Israel, looked at data from a combination of his center in Israel as well as here at MGH. And that there were more complications, and this is all comers in the young, you can see here on the left compared to the old. But perforations, there was really no significant difference in complications. But a lot of the complications that we saw in pneumatic dilation in the young were really driven by chest pain, some of which brought people to the emergency department. And you can see that actually perforations were relatively rare. And so between these two centers, it was 1.9%. And only 2 of those perforations, as I said, occurred in those over 65 years old, which was not significantly different compared to the young. Now, this is preliminary data, and there's probably some confounding by indication, meaning that myself or others who are performing the dilations in older people probably chose people that we felt may be more likely to tolerate it. And so this is not necessarily saying that all comers are safe for pneumatic dilation, but it does give you pause to say that maybe this could be a therapy in people that you may not send for POEM, you may not send for Heller myotomy. And I myself have done a 96-year-old woman, although not without reservation. What about comparison to other modalities? And here's where I'm going to present a little bit of a biased view, but I want you to sort of think of this as really multimodal treatment of achalasia, not one necessarily always better than the other. And this is the European achalasia trial that was published in the New England Journal of Medicine some years ago. And you can see the Kaplan-Meier curves here showing no difference over time between the laparoscopic Heller myotomy and the pneumatic dilation in the green. And you can see the differences in success rate, slightly higher for surgery, but not statistically so. And of course, pneumatic dilation was sort of hanging in there over time. Now, at the time that this trial was done, we didn't actually have the Chicago classification to do subtyping of achalasia. And so a subsequent look at the data, looking back at the manometry that was done in these patients, showed that the two modalities were equally effective for both type 1 and type 2 achalasia. Type 3 achalasia is another difference. Now, the key here is that redilation was needed in a quarter of patients. So when I talk to patients about this procedure, I say, you know, it is highly likely, and I say a third, that you will have to come back for an additional dilation. So when I present the option, and often I'm the one at the first level meeting these patients who are referred for dysphagia, I say, you know, if you really are a one and done, then we really should think about doing more POEM, more surgery. Again, those younger males, especially, we may be looking in the other way, and those with type 3 achalasia. But in general, I'm saying that you may have to come back. So you probably will have some significant benefit in the short term, but long term may need additional dilations. And there's no difference in the GERD by pH testing from the laparoscopic Heller myotomy versus the pneumatic dilation. Now, what about POEM, right? Because POEM is the latest and greatest. It certainly looks good. I watched the videos from the last session. And there was a 2019 randomized controlled trial, and you can see a very striking difference here between POEM and pneumatic dilation in terms of success, 92 versus 54%. Some of the problems with this study that make me a little bit dubious about its results is that they didn't allow repeat dilations, right? And I've already told you that I already sort of build in that pneumatic dilation is not necessarily a one and done, right? It's something that may need at least a second. Most people only need a second, but perhaps even a third. And the pneumatic dilation success rate that they quoted was really the lowest that we've seen in the literature thus far. The adverse events here were larger in the POEM than in pneumatic dilation, but adverse events is sort of a very broad category. These were not necessarily serious adverse events. But in terms of esophagitis, and you've heard this already, there is a big difference here, right? There was 41% for POEM and 7% for pneumatic dilation. And keep in mind that, you know, this is esophagitis alone, right? If you have GERD severe enough for esophagitis, that not necessarily includes people who have non-erosive reflux disease, which are likely higher as well. And then a small percentage of people did require a pneumatic dilation afterward. And I think this is not like one is better than the other, but this is really, we are a multidisciplinary center. So the surgeons may refer to us to do a pneumatic dilation after a POEM or a Heller. And we certainly send patients who fail pneumatic dilation to them for POEM or Heller as well. So it's nice to have all of these modalities available to use them in a complementary fashion rather than exclusively. Now, of course, this idea of GERD, you may say, well, just take a PPI and it's not a big deal. But this is what our patients are seeing, right? These are all the proposed complications of proton pump inhibitors, long-term use. Now, I spend a lot of my time in GI clinic trying to dissuade people from worrying about these complications, because with the exception of infectious gastroenteritis, most of these are associative interactions. They haven't been randomized controlled trials. And the absolute rate that's, for example, dementia up here, which I hear the most about, the absolute rate that that's going to happen with long-term PPI use may be double the risk, but it's similar to buying 2 lottery tickets versus 1. You know, you're twice as likely to win the lottery, but you're not going to quit your job in anticipation of winning the lottery. And so I think it's important to put those risks in perspective, but I do see many patients now saying, well, if I have to take a PPI, I may consider something where I don't have to take a PPI, and it pushes them away from POEM. Not necessarily a good decision, but it is a decision that is really in the media right now due to a lot of these studies. So what is the future of pneumatic dilation? I think for type 3, things are settled. But for type 1-2, the place of pneumatic dilation in the pantheon of treatments that we use for achalasia is a bit controversial. I think one of the concerning things is that pneumatic dilation is becoming less available in many academic centers in the US because people don't have the requisite expertise. I wouldn't say that it's a particularly difficult procedure, but you do want to know what you're doing and be able to potentially manage complications in addition to having the surgical backup that we benefit from at MGH. So take homes in terms of when you might consider pneumatic dilation. Types 1 or 2 achalasia, older women as we talk about, and then salvage therapy for a failed Heller or a POEM. This is where that interdisciplinary group can be helpful. And then to end, the ACG, which is the American College of Gastroenterology, has recently come up with guidelines for the diagnosis and management of achalasia. And this includes, many of the top esophageal folks, but many, I think, very reasonable guidelines. But at the end of the day, these are guidelines, right? They're based on varying degrees of data quality. So type 3 achalasia, they are recommending POEM, and that is the most effective technique. And for people with achalasia, POEM, Heller myotomy, or pneumatic dilation, POEM is associated with the highest degree of post-procedure GERD, and we've talked about that. Pneumatic dilation or laparoscopic Heller myotomy are both effective procedures for those who are to undergo definitive therapy. And specifically, they are comparable when undergoing therapy for types 1 or 2 achalasia, but knowing that your patient's getting pneumatic dilation may need more than one dilation. And pneumatic dilation is certainly something for people who need retreatment after any of the other modalities have been tried and may not necessarily have worked. And then same thing here, right? That POEM can be a salvage therapy for those where pneumatic dilation may not have worked. So a slightly biased view here, but I don't want to forget about pneumatic dilation in this group of treatments here. And I want to thank the Center for Neurointestinal Health and my colleagues in the SHED Center, many of whom you're hearing from today, as well as grant support funding my research from the NIH. So thank you.